Good afternoon, everyone. My name is Campos, a current third-year undergraduate student at UCLA. And this summer, working with Stanford's Cardiovascular Institute, I worked on hyperoxia and its associated neurologic outcomes in critically ill patients who were on Venoarterial extracorporeal membrane oxygenation, otherwise known as ECMO. ECMO is a method used by this heart-lung machine, which can be seen up here, in which blood flows out of the body and into a tube, where it is sent through a machine where it is oxygenated before it's returned back to the body. This technique tends to be used with patients who have had heart surgery or to those who present severe damages to the heart or lungs to the point of being too unstable to function on their own. The treatment has the purpose of eliminating some of the work the organs have to do in order to allow them to rest and recover. Now, there are two types of ECMO. One of them is venoarterial and the other is venovenous. In venoarterial ECMO, blood is removed from a vein and placed into an artery, whereas in venovenous ECMO, a catheter is placed in the vein. The main difference is that VV ECMO provides support to mainly the lungs, whereas VA ECMO provides support to both the lungs and the heart by returning blood to the artery where it can be delivered without having to go through the heart once again. Now, we chose to focus on patients who had to use VA ECMO for a few reasons. For one, the Extracorporeal Life Support Organization registry has shown acute brain injury to occur in 15.2% of patients in VA ECMO in comparison to 7.7% of patients in VV ECMO. In addition, there are currently recommended guidelines in place for the oxygen saturation levels in VV ECMO patients for hyperoxia avoidance, which I will speak on in a little bit, but no clear ones have been set for VA ECMO patients yet. Going into a little bit about hyperoxia, hyperoxia is a state in which excess oxygen is delivered to the body. This can happen with ECMO considering the amount of oxygen being delivered is much more than the average 20% that we are accustomed to inhaling. In previous studies, we have found a connection between the duration and severity of hyperoxia and neurologic outcome. And with our retrospective review, we hope to further explore that with our cohort of Stanford patients. Some of the common neurologic complications associated with ECMO and its induced hyperoxia include global brain ischemia as the most common type of acute brain injury, where there is basically a lack of blood flow going into the brain. Other outcomes include subdural hemorrhage, in which there is bleeding between the skull and the surface of the brain, a subarachnoid hemorrhage, where there is bleeding between the brain and the surrounding membrane, which tends to happen due to a brain aneurysm. There's also cerebral edema, which is swelling of the brain, hypoxic ischemic brain injury, in which there is oxygen deprivation, as well as common seizures. For our study in particular, we included patients who were admitted with a venoarterial ECMO for an indication for a minimum of 24 hours. The study was also limited to post-cardiotomy patients who had undergone heart surgery, as well as those who had received extracorporeal cardiopulmonary resuscitation known as ECPR, where they basically experienced a lack of oxygen before being placed into ECMO. Now, for the data we collected, we included demographic details, the initial and maximum partial pressure values, as well as the duration of hyperoxia for the first 72 hours, as well as the primary neurologic outcome at discharge. For the outcome at discharge, we based the scale on a modified Rankin scale score, in which a score of 0 to 3 was considered a good outcome, which includes the range from no symptoms to only a moderate disability where they can function unassisted, whereas a score of 4 to 6 was considered a bad neurologic outcome, where there was a moderately severe to severe disability in which the patients require assistance, even to the point of being declared brain dead. And we had a total of 52 patients in our study with an average age of about 57 years old. 75% of these patients were male, 58% were ECPR patients, and 42% were post-cardiotomy. 24 of them came from a Stanford operating room, and 15 of them came from outside of the hospital. 9 of them were admitted into the intensive care unit, and 4 were non-ICU. 42 of these patients had their ECMO cannulation first performed inside of the Stanford hospital, and 10 of them were performed outside of the hospital. And finally, their duration of ECMO ranged from 3 to 7 days, with a median of about 4 days. Something also to note was that 5 patients were also outliers with an ECMO duration of 21 days or more. So for the data collection is still ongoing for the evaluation of hyperoxia. However, considering previous evidence from other cohorts, we expect to find hyperoxia to be associated with a poor neurologic outcome in patients on ECMO. This information could promote a future direction for this project to take in order to investigate adjustments of ECMO settings, which could include possibly flow or oxygen saturation levels to decrease the risk of brain damage in potential future patients. Now, in the past time that I've spent in this program, I've not only seen my love for medicine grow immensely, but I've also gathered a much deeper understanding of the research development process itself. it's provided me skills that I think will be very useful moving forward as a scientist. And I'd like to personally thank my wonderful mentors, Drs. Karen Hirsch and Melissa Vogelsong, for their amazing guidance in this project and for also showing continuous commitment and support in my personal growth and learning as well. And I would also like to thank Adrienne Miller and the entire Stanford CVIA program and its funding sources for housing this wonderful community of scientists and providing us with so much endless support and so much, such a good time this past summer. So I would like to thank you all for everything that you've done. Thank you everyone for listening, and I will be happy to take questions now.